Good morning, ladies and gentlemen. On behalf of the Society for Health Research and Innovation, let me warmly welcome you to yet another session of the weekly Sunday webinar series. Today is the lecture 254 of our webinar series. So without further ado, let us move on to today's lecture. It will be on diabetic foot infection and limb ischemia. Our speaker for today is Dr. Nalaka Gunawansa, a consultant vascular and transplant surgeon at the National Hospital of Sri Lanka, with advanced postgraduate qualifications in vascular, endovascular, and transplantation surgery. Dr. Gunawansa is a president-elect of the Sri Lanka Society for Vascular Surgery 2025 to 2027, a past secretary of the College of Surgeons of Sri Lanka, and an executive member of the Specialty Board in Vascular Surgery at the PGIM. He has made significant academic contributions with 27 peer-reviewed publications in respected international journals. We are honored to have him today to share his expertise. Please join me in welcoming Dr. Nalaka Gunawansa for today's lecture. Over to you, sir.
Thank you. Okay, good morning. Thank you, Sri, for inviting me to give this talk. The talk today is going to be on diabetic foot infections, diabetic foot disease, and the new disease entity that we call the foot attack. So if you just put some numbers for perspective, Sri Lankan population is just over 22 million. And it's been calculated that approximately 10% of the population are diabetic. So that's about approximately 2.2 million or more diabetics in the country. And again, approximately 5% of all diabetics are found to have or known to have an active foot ulcer at any given time. So if you put that in numbers, that's more than 100,000 diabetic foot ulcers in the country at any given time. Then, leaving aside diabetes for just a second, the other important factor when you consider foot disease or foot ulcers is obviously, as you know, peripheral vascular disease or peripheral arterial disease, in this case, PAD. And PAD, the peripheral arterial disease, the incidence increases with age, as you can see on this screen, especially when you pass the age of 50. With each increasing decade of life, your incidence of peripheral artery disease increases. And when you consider the risk factors for peripheral artery disease, obviously smoking is the first risk factor, but diabetes is the second most common risk factor for peripheral artery disease. So that's where these two get combined. So you get diabetes, which causes peripheral artery disease. Diabetes is the second leading cause of peripheral artery disease, and diabetes causes foot ulcers. Peripheral artery disease causes foot ulcers, and when they get combined, you get a situation called the foot attack, where you have diabetes and neuropathy and ischemia causing progression of foot ulcers. So it's something like this. We all know, or we all talk about diabetic neuropathy. Almost everyone talks about how the legs and the feet become numb with diabetes. So that is the neuropathy. That's the neuropathic ulcer. But most of the diabetics, apart from the neuropathy, you have ischemia. And the middle picture you see, so it's basically a combination of neuropathy and ischemia causing a neuroischemic ulcer. So these diabetic ulcers are generally considered as neuroischemic ulcers. And this again shows how when your blood sugar level increases, your risk of arterial disease increases from normal glucose levels to impaired glucose tolerance to diabetes on the far right, how with your increase in blood sugar levels, your arterial disease also increases with increasing sugar levels. So what's the final conclusion, or what's the final problem that we all face? If you consider the current day population in Sri Lanka, or for that matter anywhere in the world, we have an aging population. Increasing care in the medical field has made us live longer, obviously. Life expectancy is greater. It's far greater than what it was 50 years ago. So we have an aging population. Aging population is not necessarily is a good thing, because with an aging population, you get problems that come with age. And obviously one is diabetes and second one is peripheral artery disease. So we have a higher incidence of diabetes. In addition, we have more and more younger people getting diabetes. And when you have younger people getting diabetes, that means you live longer with diabetes in your body. So you have patients who develop diabetes when they are in their late 20s, early 30s. And if they live longer, if they live up to 70, 80 years, you're talking about a patient who lives with diabetes for over 40 years of life. And diabetes and arterial ischemia together, as I said, is a match made in hell. It's an important problem, and it causes significant complications, including heart attack and the one that we are going to talk about today, the foot attack. So this is what foot attack is. It may be a new term to most of you, but it's not. It's a well-established phenomenon. When you have diabetes, infection, and lack of blood flow to that foot, that combination of those three factors is called a foot attack. They're very similar to what we would consider a heart attack in a myocardial infarction, because the term foot attack is to mean that it is an emergency. It's not just a small wound that you can stay at home and take antibiotics for. It's an emergency kind of situation where you need to seek specialized medical help, just as you would do for a heart attack. So how do we go about assessing these patients? Well, the first thing is obviously a complete history. We need to take a complete history in these patients, about their diabetes, about their control, and about their lifestyle. And in the examination, there are three basic important components that we need to do in the assessment. One is the musculoskeletal assessment. Second one is a neurological assessment. And thirdly, and most importantly, a vascular assessment. And I will go through these one by one. So neuropathy, diabetic neuropathy, everyone knows about. Everyone talks about it. But I suppose something that most of you don't understand or don't give prominence to is the fact that diabetic neuropathy can have much more greater implications and can be much more significant than what we would just attribute to diabetes. Everyone talks about the numbness and the sensation and the fact that you can't feel your feet, or you have the pinprick kind of sensation in your feet. That's just the tip of the iceberg. That's just the smallest or earliest sign of neuropathy. Remember, there are three main types of nerves in the body and in the foot. You have the motor nerves, you have the sensory nerves, and you have the autonomic nerves. Diabetes affects all three of these nerves. All three categories are affected. So what we commonly talk about is the sensory neuropathy. So when the sensory nerves are gone, you have the numbness and you have the lack of protective sensation, the reflex. For example, if our foot touches a hot surface, we reflexively take the foot away because of the warmth that we feel. But the diabetic patients lack that protective sensation. They lack the sensation, and hence they can keep their feet unknowingly on a hot surface, or they can prick themselves. They won't even know that they have injured themselves. So that's the sensory neuropathy. Apart from that, there is motor neuropathy. So the motor neurons of the foot get affected with diabetes. And what happens is that with the motor neurons getting affected, your small muscles in the foot get affected. The small muscles get wasted. There's wasting of the foot. And with the muscle wasting, there is deformity that happens, subtle deformities. These are not deformities that happen overnight. These are deformities that happen over a long period of time, 10, 20 years, so much so that the patient doesn't even know that there's a deformity. They feel that that's their normal structure, their normal appearance of the foot. But to an experienced person, you will know that it's a deformity. For example, in the top right-hand picture, yes, obviously in the right foot, a couple of toes have been amputated, but you can see the claw toe or the hammer toe in the third toe here. So those are the kind of deformities that you get, and I'll show you some more pictures of that. So that's the motor neuropathy causing muscle wasting, small muscle wasting, contracture formation, and deformity. Apart from that, you also have the autonomic neuropathy. So the autonomic nerves also get affected with diabetes, and that causes even more subtle changes like lack of sweating, loss of hair, the temperature regulation in the foot is gone. You have dry skin. You have cracks appearing because of the lack of sweating and the lack of moisture. And all these contribute to ulceration and ulcer progression. So these are some of the diabetic foot deformities. As you can see, the middle, the picture, you can see how the high arch and the claw toes, same one depicted here in the top picture, right? And a third picture lower down. So you have the claw toes or hammer toe, you have the pes cavus, and you have the rocker bottom foot. Rocker bottom foot is part of the Charcot foot changes. I'll show you a picture of that also. And when you have these deformities that take place, just if you look at this diagram, you'll see that each of these deformities contribute to foot ulceration over a long period of time due to pressure. Now, if you take the first picture, you see because of the high arch that has formed due to the contraction of these muscles, there is excess pressure when the patient stands or walks on the ball of the big toe. And also because the claw toe, the tip of the big toe is now touching the ground, not the plantar surface, but the tip. And these are the places that get ulceration. Then in this second picture on the top right, you can see a flat foot. This is part of the Charcot foot condition. And now the foot arch is completely gone, completely collapsed. And now you have pressure coming onto the middle of the foot, plantar surface. And that's a common area again for foot ulceration. And then even if you wear covered shoes, the claw toes and the hammer toes now will contribute to the top of the toes, the dorsal surface getting affected because they are now in a contractured formation, and those areas will get ulceration due to friction. So those are the deformities and how it contributes to foot ulceration. This is the Charcot foot deformity. You can see the top right-hand picture, where it's called a rocker bottom foot. That happens because the foot arch, this is the healthy foot, what we see here, and with long-standing diabetes, this middle part of the mid-foot area, these bones collapse, just like this, like a bridge collapsing. It's like a completely collapsed bridge. So this collapses, and this doesn't happen, like I said, overnight. So that the patient doesn't even know. And since they have neuropathy, they have no pain, no sensation. They think that they have had these deformities for ages, which they have had, and they think that this is the normal structure of their foot. No, obviously not. They were not born this way. But it happens very, very slowly over a long period of time, like over 10, 15, 20 years, that they are not even aware that they actually have a deformity unless someone, a specialized person, will point it out to them and tell them the dangers of having such a deformity. So that's the Charcot foot, how the middle, the bridge collapses, and now when they walk, the pressure is going to be on this area, which was never designed to bear weight in the first place, and that leads to ulceration. So apart from the musculoskeletal assessment, we also have to do a neuropathic or neurological assessment. The ideal neurological assessment is through a 10-gram monofilament, which, I mean, obviously it's a very theoretical thing. We don't have access to monofilaments, and we don't routinely do this in a basic clinic. But at least to see whether the patient has sensation of their foot, if they have lack of protective sensation, if their feet are numb, we should be able to at least ask that question and check in a clinic or in any kind of outpatient setup where we check diabetic patients. But lastly, and the most important thing, is the pulse examination. If you can take away one message from this lecture, I would say that is to examine the pulses in each and every patient, a diabetic, that comes to you. Do not ever, ever, ever let a diabetic patient go without checking pulse, because that's the least a doctor can do. That's the least a nursing officer can do. You just have to check the pulse. You have to check their pulse. You need to know whether the pulse is there, because If the pulse is there, if the blood flow is there, then you know half the battle is won. Even if they have a wound, chances are you can easily heal it. On the other hand, if you don't have pulses or pulses are difficult to feel, then you know you are in trouble. Then you know it's a losing battle unless the blood flow is reestablished. So important message for all the primary care doctors and the junior doctors: do not await confirmation with duplex scans or Doppler scans before you refer. Okay. I get this all the time where patients get referred to me very, very late, very, very late in their foot disease, sepsis. Half the foot is gone. Sometimes the sepsis is spreading so far beyond that you can't do anything. You have to offer an amputation in the first place. When I ask them why, they say, no, sir, we were waiting till we do a Doppler scan to confirm. We were waiting till we get a duplex scan before we refer. I would say that is madness. If you have a patient who has a heart disease, or if you suspect strongly that the patient is having a heart attack or ischemic heart disease, you don't wait till the patient gets a coronary angiogram to refer to a cardiologist. It's something like that. You don't do confirmatory tests before you refer. You refer and let the cardiologist, let the specialist person deal with the confirmation, right? So if you have a patient with a ischemic looking ulcer or an ulcer that doesn't heal as well as it's expected, then you check your pulse, and if the pulse is difficult to feel or absent, you refer at that time. You do not waste time waiting for Doppler scans and duplex scan, which are very unlikely to be accurate in the first place, done by a non-specialist person. Remember, doing a duplex scan especially in the periphery by a radiology group, they may not, no disrespect to radiologists, but they may not put things in perspective on a clinical sense. So with a clinically non-healing ulcer, if you have pulses which are difficult to feel, then that is an ischemic ulcer, that is a diabetic foot attack, and you have to refer that to a specialist surgeon or a vascular surgeon at that time. You do not waste time waiting for Doppler scans. So this is just a schematic diagram of how the diabetes affects the foot. As I said earlier, you have the neuropathy, sensory neuropathy, motor neuropathy, autonomic neuropathy. Apart from that, you have this side branch of peripheral artery disease, ischemia, leading to the foot at risk and foot ulceration. This is the same kind of information in a very busy slide, so I don't want you to go through the entire slide. This is pretty much the same thing, the motor sensory autonomic neuropathy going into ulceration. But the additional thing that I want you to pay attention to here is, apart from the neuropathy and apart from the ischemia that contribute to ulceration, always remember there's an additional component in diabetics, and that is that diabetics have abnormal immunity. They have impaired immunity. When you have diabetes in your body for over 10-15 years, even if your sugar level is controlled, more often than not, your sugar is not controlled, but even if your sugar level is controlled, remember, diabetes causes impaired immunity. Your immune system is compromised. So when your immune system is compromised, you have an ulcer with ischemia and neuropathy, obviously the ulcer is going to progress much more faster and become much more complicated than it would in a non-diabetic person. So in the vascular world, we consider this as a 4-step protocol for limb salvage. Limb salvage is how to save a diabetic patient's ulcer. So we have a 4-step protocol. First step is obviously to diagnose what's called double trouble. Double trouble is the ischemia and diabetes. So what we've been talking about up to now, the peripheral artery disease and diabetes. So you identify the double trouble. That's the stage 1. So obviously for that, you need to check pulses. Clinically, you can't feel the pulse. You have a diabetic patient with a foot ulcer with absent or weak pulse. That's stage 1. You identify the double trouble. Then you do number 2, which is sterilization. So obviously, if there is an ulceration, you start on some empirical antibiotics and stabilize the patient. And number 3, the one in red, the most important thing, what's called the turning point, is revascularize. Revascularize is you re-establish the blood flow. Until you do that, you're always on a bad wicket. You're always on a losing track. And as you can see here, the time frame given for that is 24 to 72 hours since the identification of the diabetic foot ulcer. So that's how fast it should be attended to. That's how fast you should act. And that's why I said, do not waste time waiting for confirmatory Doppler scan. Let the specialist, let the vascular surgeon deal with the Doppler scan, because they will do the Doppler scan in a different way for different purpose anyway. So you have a patient with a diabetes, ulcer, absent or suspected ischemia due to poor pulses. You do the referral first. Within the 24 to 72 hours, the patient will reach the specialist foot center or specialist vascular surgeon, and they will plan out the revascularization. And once you do the revascularization, stage 4, green area, which is green means safe, that is, you refine the healing process. So once you revascularize and establish the blood flow, then you can do your wound toilets and cleanups and so on, and dressings, and everything will get better as long as the blood flow is there. Remember, when the blood flow is reestablished, that's when you have a pathway for oxygen, antibiotics, nutrients, everything to come to the wound. If a leg is ischemic and there is absent pulse and no blood flow, no amount of antibiotic you give the patient is going to ever reach the foot. They're not going to reach the wound. The painkillers that you give, they will never reach the wound. The antibiotics you give, they will never reach the wound. Oxygen doesn't reach. Nutrients don't reach the wound. So that's why the wound progresses. That's why the wound doesn't get healed. So to get the wound to heal, you need the basic components coming to where the wound is. So including oxygen, protein, growth factors, everything needs to come to the wound. How they come is via blood. So if they are to come via blood, you need to re-establish the blood flow. Simple fact. So this is just to tell you the importance of this problem. If you have diabetes and an ulcer in your foot, it can be as serious as having cancer. Remember that. And another thing that I want to bring your attention to is that sometimes what you see is only the tip of the iceberg. Remember that. You only see this part. You don't see this, what's underneath the skin. And I'll show you an example of that. If you see this, the top, the right hand, the furthest on your left, actually, the furthest left picture, you see a small, tiny looking, benign kind of wound, right? Most people would look at this, would not even think it's ischemic, not even think it's anything significant. They will just say, just do a betadine dressing or do some kind of dressing and go home. But remember, in a diabetic patient, they are neuropathic. And whenever you have this, always think about the tip of the iceberg, this one, okay? And you need to ideally be able to probe the foot, right? And probing is, you don't need anesthesia for this. As you can see, as I've said earlier, they are neuropathic. They don't have sensation. And you can see if you have mosquito forceps, half the mosquito forceps is going inside. And you can see the osteomyelitis here on the X-ray, right? So this kind of patient obviously requires a radical debridement, remove this osteomyelitic bone area, and then only the wound will heal. Otherwise, this will progress and the patient will end up with a 4-foot amputation. This is another one. If you look at this picture, you see the patient has already lost a toe, and this area of the ulcer looks fairly healthy, red granulation, but you can see a tiny bit of yellowness in this corner. And when you probe, approximately 1 inch of the mosquito forceps going inside. That's because there's a tract forming there, there's an abscess forming there. And you can see, if you now look closely with that background, you can see where this question mark is, that area looks a little inflamed. That's because there's an abscess forming there. So unless you probe and get to the bottom of it literally, then you're always going to leave behind pus and leave behind infection. So the idea is to catch the patient's wounds when they are early, catch the patient's wound at this level before it goes into gangrene. Because once it comes into gangrene level, you know that no amount of revascularization is going to heal gangrene. Gangrene means it's dead, and we can't give life to what is dead. So then it's a matter of restoring. We have to then amputate the gangrenous area and then try to heal the wound at that level. So it's far better to catch it in these stages where you can actually do a small wound debridement, preserve the toes, salvage almost the entire foot rather than doing a 4-foot amputation or a complete foot amputation. Again, a busy slide. I don't want you to go through the entire thing, just to summarize what we've been talking about. So your general assessment should be looking at the patient's general condition, foot examination to check the foot pulses, the warmth, see whether there is ischemia. If there is ischemia, urgent referral to the diabetic foot center or the vascular surgeon. And then ideally you should categorize these patients. We do a categorization called low risk, medium risk, and high risk. So low risk is patients who have a callus alone. Callus is this like the thickened skin, and that callus alone with normal pulses, no actual ulceration. They are the low risk patients, and for them it's just a matter of doing a glycemic control and managing their risk factors. But then you go further, you have patients who have medium risk. Actually, those are the patients who have, apart from a wound, or they have lack of protective sensation, they have neuropathy, and they have absent pulse, ischemia. So those patients require much more intense treatment, including statins, antiplatelets, and specialized intervention. And then if you already have an ulcer or if you have an amputation in the other foot, on the contralateral foot, then that becomes a red area, the high-risk patients. So accordingly, we have a protocol of seeing these patients or review. If they have low risk, only a callus, you are expected to see them at least once a year. If they have medium risk category, that means the patients who have neuropathy, lack of sensation, you see them every 3 to 6 months. If you have an ulcer, after the ulcer heals, obviously, after the ulcer heals, you have to see them at least once in 2 months. At least once in 1 to 2 months. This is the callus I told you. Callus is thickened skin. And remember, just when you have thickened skin, you can't just let them go home. Check the pulses, and you do what's called ulcer shaving. We have had lots of peripheral workshops by the Vascular Society to show junior doctors and primary care physicians how to do callus shaving. Very simple thing to do. You can do it in your clinic setting. You can do it in the ward. You can do it in your OPD setting. You do not need anesthesia because these are neuropathic feet, obviously, and you just need a clean surgical blade and remove that callus to prevent it from ulcerating. So these are the high-risk kind of patients that I was talking about. You can see already the patient has had loss of one leg, amputation, and the second foot, again, you have a gangrene here. And if you look closely, proximal to that gangrene, there's an abscess here, pus-filled cavity. So these are the kind of patients who get delayed. And this is a patient who was referred to me almost 3 months after getting this wound. And when I checked, they have been going to the local hospital for local wound dressings, just betadine dressing. And when this became black, then they spent another 1.5 weeks waiting for a local Doppler scan, which is, I think it's just unnecessary. I mean, the patient who has already lost one leg, having a non-healing wound, going beyond 1 to 2 weeks, absent pulse, that referral should have come at that point. So just reconfirming that fact, we do not need Doppler scans or duplex confirmation for ischemia. Remember, ischemia is a clinical diagnosis. This is the same patient. You can see the abscess that I was talking about earlier. Ischemia is a clinical diagnosis. Peripheral artery disease is a clinical diagnosis, not a radiological diagnosis. So do not waste time. If you clinically can't feel a pulse, or if you feel it's difficult to feel, refer at that time. Okay. So when the patient comes to us, what we do is at the vascular center, we may do a duplex scan or an angiogram. That is not for diagnosis. That is to plan out the intervention we are going to do. Remember that. So as I said repeatedly, Doppler scan or duplex scan is not a diagnostic test. We do it to confirm how we are going to intervene. We already have made the diagnosis. The diagnosis is confirmed. Absent pulse, non-healing wound, that's the diagnosis. So you have an ischemic diabetic wound. What are we going to do? What kind of intervention we are going to do? Are we going to do an angioplasty, bypass? To determine that plan, then we look at the Doppler scan. So these are some of the surgical bypasses that we can do. You can see once you do the angiogram in this picture, you can see this is the popliteal artery here, dividing into the anterior tibial, posterior tibial, and the peroneal artery. You can see almost like a corkscrew kind of appearance. All these vessels are destroyed, no proper flow going. So these are the type of patients that we can do a bypass for. We can bypass on the popliteal, going right down to the foot and salvage it. I will show you some more pictures of that. So this is how we do this. You take an inflow, you take the patient's own vein, and then you do a bypass operation right down to the foot. This is another patient. You can see extreme ischemia, gangrene here, ischemia spreading up to the dorsum of the foot. And when you do the angiogram, you can see on the left side, multiple blocks, huge block here, one, another block here, two, another block here, three. And those are the ischemia. So we do a bypass from here to here or from here to there, and we restore the blood flow and then try to heal the wound at that point. Again, another angiogram, you can see in this angiogram, the same thing. You go into the popliteal artery, and beyond that, you can see corkscrew kind of appearance. Everything is blocked. And this is after angioplasty. This is not a bypass, this is an angioplasty. You can see once the angioplasty is done, all the three arteries are opening up. The anterior tibial, posterior tibial, and the peroneal arteries are nicely opening up. And now you know when you have the blood flow going like this, it's like opening the highway. You can now allow oxygen, nutrients, antibiotics, everything to go to the foot. And all the nutrients, all the raw material that are required for wound healing will now go to the wound. And at that point, it becomes much easier to heal the wound. Another thing here, you can see same thing, the tibial arteries are occluded. There's the popliteal artery, there's the anterior tibial artery coming, blocked from here, nothing beyond that. So we have now done an angioplasty and opened up the anterior tibial artery right down to the foot. Okay, so those are the results you get. And obviously, as vascular surgeons, we need to know the vascular anatomy. So we have the anterior tibial artery going into the dorsalis pedis here. We have the posterior tibial artery going beyond the calcaneus here. So what we do is we identify which artery is going to serve the wound better and do an angioplasty or bypass into that particular artery. So we can go right down to the foot and then try to salvage at that point. So in a fit patient, we can do bypass right down to the foot. You can see the bypass right up to the posterior tibia beyond the medial malleolus here. This is anterior tibia right at the ankle. So foot the bypass can go right down to the foot itself. And once you do the bypass or once you do the revascularization, as I said, the healing becomes much more easier simply because the raw material that are required for wound healing are now coming to the wound due to the open highway of blood vessels. So after that, it's a matter of correcting your sepsis with antibiotics, controlling your sugar, and then doing a radical debridement, and then you can do a local dressing, you can do a skin graft like this, and then save the wound at that level. So this is some of the things, same thing that I've described earlier. So I'm going to skip here, but to show you the importance of these, identifying these. Now remember, this kind of wound should never have been waiting until this stage. This should have been identified much earlier. You can see here, second, third, fourth, all three toes are gone. Third toe is completely gone, necrosis and gangrene. Second toe is 90% gone with dark color. Fourth toe, half of it is gone, and there you can see the abscess formation here. So this is obviously not something that happens in a day or two. These happen over several weeks due to delay, both from the patient and also from the medical side. A few cases before I wrap up. So this is a 68-year-old patient who came to us, diabetic for 7 years. You can see patient's ulcers. They came with fever and pain in the foot for 3 days. Because of the neuropathy, they didn't identify the earlier wounds, but when the wound became septic and developed fever, then only they got excited. Blood sugar on admission was 470 odd. Foot pulses were absent on clinical examination. The echo was only showing 35% ejection fraction. So the patient was not a fit candidate for surgery. So we did an angioplasty. And after the angioplasty was done, did a radical debridement. Now you can see all the blood coming, nice granulating tissue. Blood sugar was controlled, and we did a negative pressure dressing, a vac dressing, and healed the wound without amputation. This is another patient who came a while ago, a young guy, 46-year-old, who had an ulcer in the medial malleolar area, which was misdiagnosed as a venous ulcer, and they had been strapping in a local hospital. And obviously the strapping didn't work because they had not checked the pulses before strapping, and the wound entire area became necrosed with entire medial area of the leg becoming gangrenous and the skin going necrosed. So he was a fit guy. Popliteal pulse was absent, but distal pulses were also absent. Echo was 60%. He was fit for a bypass. He underwent a bypass. And after the femoral popliteal bypass, radical debridement of that entire area was done, and then skin grafted and saved the leg completely. So, in summary, mixed diabetic ulcers or diabetic foot ulcers are very important. The idea is to catch it early. You need to catch it early so that early intervention can save the leg and you can avoid an unnecessary amputation. So identify the neuropathic foot. When a diabetic patient comes to you, always check the pulse. As I said, that's the one thing that I want you to take away from this talk. Do not ever allow a diabetic patient to come through your clinic or come through your consultation or your private practice and go out without checking the pulse. Even if the patient does not have an ulcer, even if the patient does not complain of any illness or any problem in the legs, if you have a diabetic patient, the idea is to check the pulse, check the sensation, ask them for numbness. If they have numbness and if they have absence of pulse, you need to tell them that they are a sitting duck. They are waiting to get an ulcer, which will lead to amputation. And that's the point, that we need to take corrective measures and prevent it. Obviously, prevention is better than cure. So identify early deformities. The deformities I told you, the claw toes, the flat foot, the Charcot foot, all these things have to be identified early. This is the Charcot foot again. You can see no ulcers, but the moment you see this, don't think this is arthritis. This is not arthritis. Most people misdiagnose it as saying, that's old age and arthritis. No, it is not. It's due to the flat foot, what I showed you earlier, where your foot arch collapses over time, over a period of time, and then you have this condition where the medial part of the foot juts out with a flat foot, and that's the Charcot foot. And when you do a proper foot assessment with pressure measurements, you can see the flat foot here. What you see on your extreme left is the normal foot with the normal arch, and this is the one with the flat foot. Right? And now the importance of this picture is when they walk, they bear weight on this entire area, and the mid part of the foot was never designed, or we were never designed as humans to bear weight on this middle part of the foot. And when you have pressure coming, especially in an obese patient who's 70, 80 kilograms or more, you can imagine when they walk, with each single step, pressure coming onto this area, that's how ulceration starts. So for those patients, we have specialized footwear, what are called patella weight bearing. These are available in Sri Lanka. Don't think that they are not. They are available. It just needs to be referred to the proper place. So you can give them what's called a patella weight bearing device. They are a bit cumbersome to wear, but then I always tell the patients, you just have to get used to them. There are people who start wearing glasses. Initially, it's a cumbersome thing, but once you start wearing, you can't live without it, something like that. So once you start wearing these devices, initial 1 to 2 months, they will be cursing you, but after that, they will come and tell you, oh, thank you, doctor, I feel so much better. So it's just a matter of pursuing and persisting and persevering. Same thing here. You can see ulcer in the healed area that has been healed now after this patient had a bypass operation and the healers was healed, and a simple adjustment to the foot, the footwear, the shoe. You can cut part of this area out, and you have a offloading shoe where when the patient walks now, the weight will be on the front part and the ulcer area doesn't bear any weight, and that you can prevent recurrence of the ulcer. So again, in summary, diabetic foot disease is extremely common. Ischemia is deadly. Sooner you identify ischemia, the higher the chance of limb salvage. So examine the foot thoroughly, examine the pulses, always check pulse. Do not waste time confirming it Doppler. Let the vascular surgeon or the specialized center deal with your Doppler. Your job is to identify absence of pulse or suspected ischemia and refer early. Few things that you can tell the patients about: how to clean your feet, how to keep them clean, to teach them how to examine their feet for ulcers, wounds, cutting nails, just to keep general hygiene going. So diabetes and ischemia threatens both life and limb. Identify early and we can save both the life and both the limb. Thank you.
Thank you very much, sir. We have few questions in the chat box.
Yeah.
Are there any prophylactic effect of low-dose aspirin and other anticoagulants to prevent limb ischemia due to vascular origin in diabetic neuropathic patients?
So the issue is this. Obviously, statins and antiplatelets, aspirin or clopidogrel are indicated if the patient is having peripheral artery disease, or for that matter, coronary artery disease. So any patient who's above 50 years old, I would say, who has any symptoms of peripheral artery disease with absent pulse, reduced pulses, or having coronary artery disease, they will be required to be on an antiplatelet and a statin anti-cholesterol drug. Generally, these patients are started on these antiplatelets and cholesterol drugs by the cardiologist or their physician as a general rule. But if you identify these diabetic patients with poor pulses, absent pulses, even without ulceration, yes, there is definitely a place for prophylactic long-term aspirin and statin anti-cholesterol drugs. Yes.
So can eczema in legs can be a precedent symptom for peripheral arterial disease?
Eczema per se is not a precursor of peripheral artery disease. Eczema is generally a precursor or generally a condition associated with varicose veins. So if the patient has varicose veins, yes, you can have venous eczema. But having said that, remember, there are patients who have mixed ulcers. They have varicose veins, they have peripheral artery disease, they have diabetes. If you think about it, you imagine a 60-year-old woman with diabetes and varicose veins, right? The diabetes will cause the peripheral artery disease also. So now you have a mixed bag. You have a mixed picture. You don't have a clear-cut thing. So the patient will have varicose veins, they have eczema, they have absent pulse, so everything put together. But the direct answer to your question, eczema does not necessarily cause or is a precursor of peripheral artery disease, but whatever patient that you have, if you have a wound or if you have a skin condition in the foot or in the leg which is not healing as well as you expect it to, always suspect arterial disease and check the pulse.
So is there any way to improve the limb vascularization in a patient who is not willing to undergo vascular surgery?
So obviously it's like this. If you do not have ulceration, if you do not have an ulcer, you do not need immediate revascularization at that point. If you have an ulcer, if you have an active wound, a diabetic foot wound or an active ulcer with absent pulses, then there is no choice. You need to have a revascularization. You just have to simply tell the patient with an active ulcer, the ulcer is never going to heal without blood flow. No amount of wound debridement that you do or no amount of fancy dressings that you do is ever going to heal, as I said, because you lack the basic things coming to the wound, the oxygen, the nutrients. Nothing will come to the wound without the highway being open, without the blood flow being open. So in that instance, you need to tell them by delaying revascularization, you're just delaying the healing process and eventually end up with an amputation. And most of these patients become septic, and by the time they finally realize, yes, I can't stay like this, I have to go, by that time it's too late. And you need to tell them early and catch them and educate them early. And in my almost 15, 20 years of experience as a vascular surgeon, remember, if you have a honest conversation and explain to them and explain to the family the implications of not doing it, 99% of the time they obviously understand. It's a matter of if you just straight away go and say, you need to have an operation. Yes, no one will like an operation, but you need to tell them the implications of not doing it, not doing a revascularization. On the other hand, if the patient does not have an ulcer, does not have a wound at the present time, and if the patient is diabetic and has absent pulses, then to improve the blood flow, you can do, as we said earlier, you can start on the aspirin, you can start on the statins, you control the diabetes. If they're smokers, you control the smoking. So you control all the risk factors. You what's called risk factor modification. You control the smoking, control the diabetes, control the hypertension, control the cholesterol, add the antiplatelet drugs, get them to walk. Walking will improve the blood flow also. So those are all when you don't have a wound, right? So on the flip side, if you already have a wound and an ulcer, then you can't ask them to walk. Obviously, with the ulcer, they can't walk, and then the stage is too late for just conservative measures.
If the patient is not clinically or biochemically septic, but the patient is having an unhealing wound, is IV antibiotics helpful?
IV antibiotics are helpful only if there is local or systemic sepsis. You can't just give IV antibiotics at the presence of a wound. Again, we come back to the same thing that I keep saying to you all over again. When the patient has absent pulse or ischemia, no amount of IV antibiotics you give are going to reach the wound. Once you give an IV antibiotic into your cannula, into a vein, you expect that antibiotic to go to the heart, get pumped through the arterial system and go to the wound. How can it go to the wound if there is no pulse, no blood flow? So no IV antibiotics is going to replace. So IV antibiotics is not an alternative or replacement for revascularization. Simple as that, right? So if you have a block, you need to correct the block, and then you can give IV antibiotics to heal the wound. But in a primary care setting, if you have a wound and if you suspect infection, you need to obviously take a pus swab or a deep tissue culture. Based on that, you need antibiotics, empirical antibiotics, until you go and get the revascularization done. So you don't just not give anything. You give an antibiotic, but you give an empirical antibiotic, ideally after taking a swab. This is another problem that I see in most patients who get referred to me. They have been having wounds for a long time, never even thought about taking a swab or a pus culture. They have been on all antibiotics. So starting with the simplest of something like ciprofloxacin, giving it for 1 week, no answer. Then they give augmentin, coamoxiclav, no answer. Then they go to clindamycin. So by the time they come to us, they have been on oral antibiotics, about 4 or 5 different antibiotics for a long period of time. And now they have developed resistance also. And even if we do a culture now, obviously culture won't grow anything. And so now we have to grope in the dark. So simple answer is, if you have a wound, and diabetic foot wound, always take a swab first, send it for culture, then start on empirical antibiotics, because then when you have taken a culture, you have something to go by. And afterwards, if there is progression and if there is no proper signs of healing, don't waste time, do the early referral. Early referral saves lives and saves limbs.
Is there any place for prophylactic antibiotics for patients who tend to have recurrent ulcers?
No, not for recurrent ulcers. If you have recurrent cellulitis, yes, there's a place for prophylactic antibiotics at a low dose, long term, but there is no place for prophylactic antibiotics for a patient who has had a wound and when the wound has healed. Because once the wound has healed completely, there's no point in giving antibiotics, because you're only going to get side effects of the wound, and the patient is always going to develop resistance after that.
What is the recommended wound dressing method, and what can be used in for diabetic ulcers?
It depends on the different stage of the wound and depends on the patient. So there is no universal dressing anyone can recommend for all wounds, right? It's like, you go to a buffet for lunch. There are different types of food and different people like different things. Similarly, different type of wounds at different stages in different people require different things. So depending on the nature of the wound, if there is pus or if there is no pus, if there is granulation, if there is necrosis, if the wound is dry, if the wound is wet, depending on those factors, you have multiple dressing techniques, and that's a different topic altogether. I can talk another 1 hour for that. So that's a different thing. So the short answer to your question is there is no universal dressing that you can say, put this in all diabetic wounds. It doesn't work that way. It depends on the nature of the wound, size of the wound, location of the wound, and so on. So obviously, if it's a heel wound where the patient, when he walks, will put pressure on it, you need to put an offloading dressing. If the patient is having a necrotic dry wound, you need to keep it moist. If the patient is having a moist wet wound, you need to keep it dry. If the patient is having a cavity, you need to pack the cavity with something. So it depends on the nature of the wound, as I said.
So is there any good effect with transcutaneous electrical nerve stimulation to improve circulation?
Yes, theoretically, yes, on the long term, but like I said, it's highly theoretical. So when you have a patient with a diabetic foot wound, giving transcutaneous electrical stimulation, how fast do you think this will improve the blood flow strong enough to heal a wound? These will take months and months and months and months and months, right? So unless the patient has a before the patient develops a wound, yes, you can do that as a prophylactic measure. Again, highly theoretical, because the patient will not be doing this at home continuously, or they will not be coming to hospital to get electrical stimulation. But when a patient already has a wound and has an infection, as I said, what we were talking about, having a diabetic foot attack, then it's too late to be doing electrical stimulation. It's like when the patient has had a massive myocardial infarction, then there's no point in saying, okay, let's stay at home and control your sugar. You need to revascularize and then control your sugar, something like that.
We have a lot of questions asking about the local applications that we can use for dry and wet wounds.
Yeah.
You have a short time to explain that.
Yes. So again, there are lots of dressings in the market, and what dressing you put on a wound, as I said, depends on the stage of the wound and the nature of the wound. For example, in my own practice, what I use today for a particular patient for a particular wound may not be the same dressing that I put when the patient comes back in 3 days, or patient comes back in 1 week. Okay, so there is no single dressing that you can give to all patients. It depends on, even in the same patient at different stages, it differs from stage to stage. But a simple thing is, I can't give you commercial names at the moment. I don't think it's ethical to give you commercial names in a big gathering like this. But there are lots of commercial preparations. The simplest non-commercial things are like things like Vaseline gauze, which you can use for any dry wound. You can use acetic acid, that is 0.5%, very, very dilute acetic acid for wounds where you think there is Pseudomonas, the greenish color infection. That's a local antiseptic, the acetic acid, that will get rid of some of the green color and the Pseudomonas on the surface, which acts like a biofilm. But remember, it has to be very diluted. It's 0.5%. You have to specify and get it from a main pharmacy. So those are the local things that you can use. Then you have the different gel, starting with lidocaine gel, which is the easiest to find in a simple hospital, but there are much more sophisticated gels in the market which have incorporated local antibiotics like metronidazole, clindamycin, and so on. So they will have a limited effect. Remember, when there is systemic sepsis or local sepsis and cellulitis, putting a local antiseptic doesn't really heal the wound, but at least it will decontaminate that area and then keep the wound stable enough until the patient goes to a specialized center. So it's a temporary thing that you can do. So for dry wounds, you can use different types of gels. And for wet wounds, wounds which are oozing out, then you need a dry dressing. You need something which will absorb it. So there are the foam dressing, what I call foam dressings. Again, lots of foam dressings in the market. You can find, as I said, I don't want to give commercial names right now, but there are several foam dressings which are silver impregnated, which are copper impregnated. So a lot of dressings that you can use when it's oozing a lot of fluid for absorption. So simple thing is, if it's an oozing wet wound, put an absorbent dressing. If it's a dry wound, make it slightly wet by putting a gel. If it's a cavity, you need to pack it. If it's a surface wound, you can put something like, as I said, Vaseline gauze. If it's a wound with a greenish color tinge with possible pseudomonas, you can put 0.5% acetic acid dressing, and then be open and flexible. Don't think, this is the patient, this one, I'm going to only use this until the wound heals. It doesn't work that way. What you do today, for example, you put say you put a Vaseline gauze today, or you put acetic acid today, and when you see the patient in 3 weeks, in a week's time, if the wound is now dry, then you change over to a wet dressing. If the wound is wet, then you go on to a foam dressing. So you have to be flexible and make that decision depending on what you see at that particular point.
Okay, so we have come to the end of the time that is allocated for us. To wind up the session, I would ask one last question. There's a recurring question. What are the centers that we can refer the patients for revascularization, facilities that has revascularization in Sri Lanka?
So a lot. So we have a lot of vascular surgeons in Sri Lanka now, almost 20. So all the main centers, obviously the National Hospital Sri Lanka is the biggest center. We have 3 different vascular units in National Hospital of Sri Lanka, including my own unit. Then there is in Ragama, then there is in Gaul, in Kandy, Peradeniya, Anuradhapura, Ratnapura, Kurunagala, Padulla, Polonnaruwa, Batiklo, Jaffna. All the main hospitals have a vascular center now and with a vascular surgeon. So specialist vascular surgeons are available throughout the country, and you just need to find out the closest possible place for you and as well as the patient. And they will have their own expertise and their own teams, and they will do the maximum and salvage the limbs.
Thank you, sir. So on behalf of this Society for Health Research and Innovation, I would like to extend our greatest and sincere appreciation to Dr. Nalaka Gunawansa for delivering this excellent, insightful, and highly educational lecture. We are truly grateful for your time, your expertise, and your valuable contribution to today's sessions. Thank you very much, sir.
Thank you.